Good evening. My name is Gwendolyn Joy. Today is April 27th, 2025, and this is Weeks 5's Case Studies Connections. Can't believe they're already on 15 weeks. Just one more to go. This has really flown by, but let's jump in. I will be discussing cases 3 and 4 out of the case study not suggestions, but from the case studies that we were allowed to pick from. The list. There we go. That's the word, the list. First, I'll be discussing case 3. And in case 3, there was a 47-year-old man that had presented with gout. And the first question is asking for us to explain why the gout on this event, what is the best explanation, for the gout. And I chose the answer C, which is a decreased urinary excretion of the uric acid. And the reason why I chose C was because the patient's the patient's plasma urate level is elevated to 10 milligrams DL. This indicates the hypersemia, which is a key factor in gout. Another thing that the urinary acid excretion is low, being that it's 215 milligrams within the 24 hours, which also suggests that the kidneys are not adequately removing the uric acid from the body, which is leading to its accumulation in the blood. Another thing to further prove that C, the decretion and excretion, would be a 24-hour urine collection for the uric acid in the creatine clearance, which could also be performed to assess the kidney function. The reasons why I don't feel that A or B are likely is because for A, the overproduction of purines, which just likely results in both high plasma urate and urinary acid levels. So those will both be high instead of what we're seeing in the patient, instead of one's not as high as the other. Just to go back, our patient has normal plasma urate the normal plasma urate is 7, and our patient has 413. Am I looking at this properly? Sorry. Correction. The plasma rate is greater than 7, and our patient has 10.5. So we're doing well. And the urinary acid is 413 plus or minus, give or take, of 78, and we are at 215. So they're not crazy. It's on the lower side versus within that higher norm, as we could say. And just to go back, another reason why B, some more reasons why B, the decreased salvage of prunes. One, that this is more of a rare case and it doesn't happen that often, especially with the symptoms that our patient presented. But this would this would likely increase both the plasma and the urinary acid. And then moving on to question 2, the potential impact of dietary modification, the increased regular soda consumption on the gout. So the switch over to regular soda, one, that means that the patient would be consuming more and high fructose corn syrup, which is just likely to exacerbate the patient's gout. So not helping, just further harming them. The fructose metabolism can lead to an increase of uric acid production and decrease uric and acid excretion, which is also worsening the hyperurinuria and triggering the gout flares. So again, it's just worsening the patient's symptoms, not helping them progress, and they're just feeling worse. The large amount of soda consumed, which is roughly 4 to 5 daily, that is a lot of soda, but that would just significantly contribute to this effect. Again, just furthering worsening their conditions, uncomfortable. And now we're moving on to case 4. And in case 4, there's a 58-year-old woman who's presented with emergency. She has fatigue, weakness for the past 6 months. She's also just getting shortness of breath, but after walking several blocks. I feel like anybody that walks several blocks, eventually they're going to be a little short of breath. But she's, for the most part, she has normal levels of other things, but she is also noticing signs of numbness, tingling, and her lower extremities, and the loss of balance while walking, which isn't great. So question 1 is asking which of the following vitamin deficiencies would most likely be the cause and present within this patient. And we are choosing between iron, B6, and B12. And within this case, so iron, it can cause fatigue and weakness. However, it doesn't normally coincide with each other, so you usually don't get both at the same time when it comes to an iron deficiency. But the neurological symptoms point kind of a little bit stronger to another symptom, vitamin deficiency, but I'll explain a little bit more which one it actually does refer to. So in B6, the deficiency can cause neurological symptoms, but it doesn't, again, cause the combination of these two seen together, including the beefy tongue and the beefy and red tongue and the megaballistic anemia. There we go. So you're just not going to see that whole combination with a B6 deficiency. Whereas in B12, which is what I feel like it's mostly closely related to for this patient's out of their symptoms and what they're presenting, they're showing, again, signs of fatigue, weakness, shortness of breath, and they're having neurological symptom problems with the beefy red tongue, and it just more than the other two, it strongly suggests that this is what their vitamin deficiency is. And again, just to kind of go back over what those other neurological symptoms were, again, just having numbness and tingling, and then she's also just having mild diarrhea. So again, it's just further coinciding with the B12 deficiency. Moving on to the part 2, so question number 2 for case 4, B12 deficiency. The impaired furon and pyrimidinic metabolism, which in B12, it is a crucial function for the methylene synthesize, which is an enzyme involved in the synthesis of methionine from homocysteine. The methionine is needed for the formation of the or the SAM, so the S-androlismia and androlismia 9. I'm struggling. Should have looked that one up a little bit harder, but which is a methyl donor essential for many biochemical reactions, including the synthesis of purin and the pyrimidines. These are the building blocks of DNA, and then B12 deficiency leads to the buildup of the homocysteine and the deficiency of methionine and SAM, which is also impairing the DNA synthesis, causing metabolic anemia. Some laboratory tests and findings that we can use is CBC, which is a complete blood count, with the perihemial smear, the microcystic anemia, which shows the hypersegmentate. My word, science is hard, and so are words. Hypersegmented neuropathies. Got there. You can also do a test for vitamin B12 levels with the low serum, the B12 level. And then we also have the MMA, so the methylmalonic acid in the homocysteine levels, which is an elevated MMA, and homocysteine levels which are more sensitive indicators of B12 deficiency rather than the serum B12 alone. So it kind of helps just further prove and push a little bit more besides the vitamin B12 level test. And then you also have the rectocellulite count and the low or the inappropriate normal, which can indicate impaired red blood cells production. And then the another test is antibodies to intercystic factor in the perianthal cells, which assesses for pernicious anemia. And then the last one is folate level, which is to rule out the folate deficiency, which can also cause metabolistic anemia. And there we have it for our case studies for week 15. And again, I went over cases 3 and 4. Have a good one. Looking forward to, well, actually, I'm not really looking forward to our final week, but until the meantime.